Our final speaker, Assistant Professor Likhit Ratphulmeung from Sirat Hospital, will talk about medial plating in distal femur fractures, indications and techniques. Please.
Good morning, Chairman, Co-Chairman, and other audience. This topic would be the medial plating of the distal femur fractures. So I'm going to begin with the cases. You have to know the development of the medial plate, why it has to be occur in this area. The first one is the 64 years male has been treated with the double platings. It can also see that the consolidation is quite very good on the healing process, and it ends up with very successful treatment. For another one, the 50 years old females has been treated with just only single plate. How can it be healed very good like this? What are the concepts behind? What are the principle behind why the different type of the device can also end up with the same result and very good result? So we have to look into the detail of the principle. For the concept of the development of the medial plate, it occurs because of the failure of the lateral plate constructs and end up with the new thinking about the additional plate or the augmented plate. So in the case just like the osteoporotic fracture, the comminuted fracture, or even some specific type of the fracture, such as the periprosthetic fracture, sometimes it ends up with a failed construct. So the medial plate is quite indicated. So there's now several company or several manufacturer has been developed to introduce into our communities. The medial plate has been once used by another area of anatomical plate, and nowadays we have some of the manufacturer invent the specific type of the medial plate. You can see here from the slide. For the indications for the medial plate or the double plate, we have to use, especially for the very distal fracture line, the medial complex, the medial cortex loss, the osteoporotic bone, or even the very comminute of the F-type and C-type fracture. Sometimes we use in the periprosthetic fracture in the very displaced of the periprosthetic one, such as the Lewis and Lorbeck 2, or even the side type 2 configurations. For the timing, there's a controversy about the timing of the plate. Sometimes we recommend to do a plate concomitantly with the lateral plate, but in some area of the world, they recommend to do a medial plate just after the lateral plate and wait for some of the delay union to occur. But we do not sure whether which one would be good. We still recommend to do a varus and vagus stress test at the scenes of the when we do the lateral plate fixations, when we do not sure whether there's some of the displacement of the fracture site or some of instability of the construct, we recommend to use a medial plate or the additional plate. For the disadvantage of the medial plate or the double plate, most of all we have to increase the operative time and increase the blood loss, and sometimes it ends up with the overstability of the constructs. And sometimes it can end up with the jamming of the distal screw fixation, especially for the locking plate that has no VA involvement. I mean the variable angle involvement in this plate. And it can also cause the injury to the deep femoral artery if we do not careful enough. For the sequence of the platings, I recommend to use a lateral plate first. The lateral plate should be long enough to cover the medial plate. If we do not quite sure whether we're gonna put the medial plate, we have to cover the area of the medial plate at the first time, and we have to secure the screw, at least 4 to 5 screw for the proximal fragment and 4 to 5 screw at the distal fragment. You have to remember that after we do the lateral plate, we have to test the stability for the constructs. If there is displacement of the fracture site, so the medial plate is indicated. For the buttressing effect of the medial plate, you have to bear in mind that if there is this cover of the medial plate over the medial fragment, it can also cause the failure of the medial plate placement. Most of the time, I use the Philos plate as a treatment of choice. For the pitfall, the malreduction, it can occur even you just use only the single plate, the lateral plate. But if you do the medial plate, it can also end up very devastating effect after we do the malreduction of the lateral plate. So another one is the golf cup deformity. It can occur because of the distal placement of the lateral plate, or sometimes we do a malreduction of the lateral plate and end up with a gap on the middle side, and the medial plate cannot cover quite properly. And another one is the failure of the fixation. If you just only put the lateral plate and without knowing the stability of the constructs, it will end up like this. It will end up with the failure of the component. This one is also indicated for the medial plate. If we put the medial plate in the wrong place, you can see here from the slide, it can also cause the malreduction and also cause the displacement and end up with the failure of the constructs. You can see here, even we put a medial plate, it cannot be guaranteed our successful all the time. So we recommend to use a pre-contour plating for the medial side in order to catch all the fragment on the medial. Another one is the fracture of the 61 years female, but this one is quite very special one. You see, the surgeon decided to go on with the double plate and end up with the non-union. How can it be occur if we decide to go on with the double plating and end up with the non-union? Because of the surgeon did not test the stability, it is a very rigid construct and end up with a non-union. And also you can see the gap at the fracture side. It will be left with non-union like the gap like this. So there's now invention from the AO group. You can see here this biphasic plate. It can also help in help us to get a very good environment at the fracture site and cause a very good callus formation. You can see here from the stress and strain curve like this. It can also provide a very good stress and strain area to get a very good callus formation. Another thing you have to bear in mind about the medial plate placement, if you try to do a minimal invasive technique, it can also cause a danger to the deep femoral artery. You have to know the safe zone. The safe zone is 15 centimeters below the lesser terquenter to the medial condyle. If you did not involve very much proximally, you can do very safely in this kind of techniques. And for about the issue of the combination of the implant, we can also do that by dual plating or the plate and nail constructs. But which one should be used? You can see here from the slide, for the mechanical stability of the double plating, it has a very good comparing to the nail and plate constructs, even in the synthetic model and cadaveric model on both of the torsional stiffness and axial stiffness. If you'd like to get a very good construct or very good fixation, I think the double plate is quite the key answers. And the buttressing, you have to bear in mind, another one is the buttressing effect of the medial plate. You have to put the surface area of the medial plate over the fragment. If there is no placement with a very good area, it can also cause the failure, as I mentioned earlier in my slide. Another one is the fracture of the periprosthetic fractures. You can see here, this is the 81 years old female has been sustained the fracture of the periprosthetic fractures. This has been classified as a Lewis and Laura Beck type 2 and Su type 2, which means that there is a very displaced of the fracture site, and the fracture has occurred at the level of the anterior flank of the femoral component. We have several issues about the treating options, but today I'm gonna use the double plate. First, I do the reduction first by use the circlage wire. And then I do a lateral plating to secure all the fragments. The lateral plate has to be long enough to cover the medial plate if we decide to go on after we test the stabilities. I do a fixation at least 4 to 5 screws at the distal fragment and 4 to 5 screws at the proximal fragment. And then I test the stability of the construct. If there is a movement at the fracture site, I recommend to use a medial plate as an additional plate. This is the construct in finish. You can see here there's a very good reduction, and I think it is a good construct. And you can see from the 11 months after the operation, the callus has been occurs, and then the patient can walk very well afterwards. So for the conclusions, I recommend to do a preoperative planning quite very meticulously in order to show the which fragment you're gonna fix or which fragment you're gonna hold with the butt dressing effect of the medial plate. And I recommend to use a stress test as a determiner for whether we go on with the medial plate or not. And then if you go on with the, you have been encountered with the periprosthetic fractures, you have to bear in mind that sometimes the distal component of the femoral component, the femoral component can also be dislodged, and we have to use a backup revision set. It may be occur sometimes. And I recommend you to learn from other mistakes. Otherwise, somebody will get hurt if you do not learn some things from the development of the plate. And also, our human species can progress through the education. If we learn from ourselves mistakes, no nation will try. We have to learn some things from other bodies. Thank you.
Thank you for the great topic from the Assistant Professor Likhit. The next one is a question and answer. Any question from the floor from the participant?